In this video, we'll be covering drug-receptor interactions. Recall that receptors are proteins responsible for transmitting an external stimulus into an internal signal. Because receptors are so critical for how cells respond to their environment, they make great drug targets. A great way to understand drug mechanisms and properties is by seeing how they affect receptor signaling using a dose-response curve. These curves are very similar to the Michaelis-Menten curves we talked about back in enzyme kinetics, but instead of plotting substrate concentration on the x-axis, they plot ligand concentration. Recall that a ligand is just any substance that binds to the receptor. So this could be either the receptor's endogenous binding partner that's naturally found in the body, or it could be a drug that's been designed to interact with that receptor. And then instead of having initial velocity on the y-axis like we did for enzyme kinetics, we're going to have receptor response. So usually that's going to be measured with a secondary signaling molecule that's downstream of the receptor signaling pathway. So for example, let's consider the mu-opioid receptor, which is a GI-coupled receptor. The endogenous ligand or binding partner of the mu-opioid receptor that causes signaling in the body are endorphins. A major secondary signaling effect of ligands binding to GI-coupled receptors like the mu-opioid receptor is a decrease in cyclic AMP production. So if we define the y-axis as the decrease in cyclic AMP levels over the maximal amount of decrease in cyclic AMP levels that maximal signaling of the receptor would produce, we can see that as endorphin concentration goes up, the signaling of the opioid receptor increases until it hits a plateau. And this plateau describes the efficacy of the ligand. So that's going to be the maximal amount of signaling that the ligand binding to the receptor can produce. This is very similar to the concept of Vmax that we talked about for the enzyme kinetics video. And then the potency describes the concentration of the drug required to produce a particular effect. This is often measured by looking at the EC50, which is the concentration required to produce 50% of the maximal effect. So if this here is 50% of the maximal effect for this ligand, the EC50 is going to be somewhere around here, with lower EC50s suggesting higher potency. This is very similar to the concept of the Michaelis-Menten constant, or the Km, that we talked about for enzyme kinetics. Aside from each drug being able to be characterized by its efficacy and its potency, there are also different kinds of interactions that can occur between the drug and the receptor. And looking at the dose-response curve is a great way to identify that mechanism. The first major class of drugs that interact with receptors are called agonists. When agonists bind to their receptor, they cause a physiological effect. In other words, they directly affect the signaling pathway of the receptor. When full agonists bind to the receptor, they produce the maximal effect that the receptor could possibly produce. So often these are on par with the endogenous ligand of the receptor. An example of a mu-opioid receptor full agonist is fentanyl. When fentanyl binds to the mu-opioid receptor, it leads to a decrease in cyclic AMP levels with similar efficacy to the endogenous ligands. So the concentration response curve for fentanyl will look something like this. We can tell it's a full agonist because it's reaching 100% of the maximal receptor signaling. This makes fentanyl a very effective medication for treating severe pain, but it also means that other opioid receptor effects that are less desirable, such as decreased respiratory rate, are also going to be more likely to occur. There's another class of agonists called partial agonists, and as their name implies, these agonists cause partial signaling but not full signaling at the receptor. So they have decreased efficacy relative to the full agonists. An example of a partial agonist for the mu-opioid receptor is buprenorphine. And when buprenorphine binds to the mu-opioid receptor, it does cause a decrease in cyclic AMP levels, but not to as much of an extent as the full agonists fentanyl or endorphins. So the curve for buprenorphine is going to look something like this, with the curve plateauing out at a lower efficacy than the full agonists. This medication can be used for pain relief, and it's also commonly used to treat opioid use disorder because the lower level of signaling is enough to reduce opioid withdrawal symptoms and cravings, but not enough to cause dangerous respiratory depression at most doses. Notice that the potency is not relevant for figuring out if something is a full or a partial agonist. We just look at the efficacy level. There's one last kind of agonist that I'll mention, and these are called inverse agonists, which produce a signaling effect that is in the opposite direction of the typical signaling effect of the receptor. So for example, an inverse agonist binding to a mu-opioid receptor would lead to an increase in cyclic AMP instead of a decrease. How is this possible? Inverse agonism can really only occur in the context of something called constitutive signaling, which is when the receptor is able to have a low level of activity even if there is no agonist bound. That means that when the inverse agonist binds to the receptor, it stops that constitutive signaling from occurring. So if there was normally some basal level of signaling causing a decrease in cyclic AMP, that's now going to stop occurring, leading to an increase in cyclic AMP signaling overall. There's mixed evidence on whether or not opioid receptors can constitutively signal, but it seems that it might happen in some area of the brain. So naltrexone is a drug that's been described as either an inverse agonist or just an antagonist, depending on the context of whether or not that constitutive signaling is present. Moving on now to antagonists, these are a class of drugs that instead of inducing a physiological response, block a physiological response when bound to the receptor. There's two different kinds of antagonists, and they're described by where on the receptor they bind. Competitive antagonists bind to the orthosteric site, which is defined as the site that the endogenous ligand binds to. So competitive antagonists must compete with the endogenous ligand for the receptor binding site. If we set up a dose-response curve experiment where we first expose the receptors to a constant level of an antagonist, for example, the mu-opioid receptor antagonist naloxone, the naloxone is going to occupy the orthosteric site of the receptor, which is where the endorphins normally bind. And then if we start adding in an increasing concentration of endorphins, those endorphins are going to compete off the naloxone from the orthosteric binding site in order to induce signaling or decrease in cyclic AMP. However, it's now going to require an increased concentration of endorphins to induce the same effect as without the naloxone bound. Since the endorphins now have the added challenge of competing off the naloxone, it's going to take a higher concentration of endorphins to induce the same signaling effect without the presence of naloxone. That's going to make the endorphins appear to have a lower potency. But at high enough concentrations, the endorphins will eventually compete off all of the naloxone, and the receptor will be able to signal at the maximal level that it was able to before. So we can recognize that naloxone is a competitive antagonist by noticing that it decreases the apparent potency of the endorphins, but does not have an effect on the efficacy. This is exactly like the concept of competitive inhibition for enzyme kinetics. Non-competitive antagonists block signaling by binding to an allosteric site, which is any site other than the binding site. If we set up the same experiment we had before, where the receptors are first exposed to the antagonist, which is binding at a site other than the agonist binding site, and then are exposed to the agonist, the potency of the agonist will appear unchanged because all of the agonist binding sites remain unoccupied, and the agonist can still bind to them. However, the efficacy is going to decrease because no matter how much we increase the concentration of the agonist, it will never be able to compete off the antagonist because it's binding at a different site. This is exactly like the concept of non-competitive inhibition for enzyme-drug interactions. There aren't really any good examples of opioid non-competitive antagonists, but ketamine is a non-competitive antagonist for a different class of receptors called NMDA receptors. To summarize, receptors are very common drug targets, and dose-response curves are great ways of assessing the mechanisms and properties of a drug. A super common step 1 question will show you a curve like these and ask you to compare the potencies or efficacies of two curves, identify if something is an agonist or an antagonist, or identify if it's full, partial, inverse, competitive, or non-competitive. Agonists bind to the receptor and cause physiological signaling. Full agonists cause the maximal effect, while partial agonists cause an effect that is less than the maximal effect, so they have a decreased efficacy. Inverse agonists will cause opposite signaling effects in the context of constitutive signaling. Antagonists block signaling, with competitive antagonists decreasing the apparent potency of an agonist, and non-competitive antagonists, decreasing the apparent efficacy of an agonist. These concepts parallel nicely to enzyme inhibition. Before wrapping up, I want to point out a common pitfall. Notice that the curves I drew for the agonists and the antagonists look pretty similar. So for example, how are you supposed to tell apart a partial agonist from a non-competitive antagonist? The way you do that is by paying attention to the context of the experiment from which the dose-response curve is derived. Antagonists block signaling. So in order to assess how antagonists affect receptor signaling, the receptors need to be exposed to the agonist and the antagonist simultaneously, which I've shown in the lower graph and in these lower depictions of cells with receptors. To assess agonist function, the receptors can be exposed to the agonist alone, like we did in this upper graph. If we exposed receptors to antagonists alone and looked at the signaling, it would just look like this line, because all it would do is block signaling, whether or not it is competitive or non-competitive, and we wouldn't be able to tell apart the mechanisms.